Welcome back to session 2 of day 1 of Rhythm Interventions Online 2025. Thanks for joining me in a cold and wintry London. The focus for this session is precision and control in a challenging ablation case. And for this, we're delighted to bring you a live case from operators Jérôme Lacotte and Vladimir Manenti from Hospital Privé Jacques Cartier, Massy, France. Before we join them, let's meet our expert panel for the session, and we are delighted to have Dimitris Tsiachris from Athens in Greece, and welcome back RIO course director Devi Nair. Before we join the case centre, remember we are live and have a faculty of great experience, so please join the discussions by submitting your questions. So I'm going to hand over to our operators now. Can you hear us in France?
Yes, welcome to Paris. It's Dr. Lacotte speaking. Can you hear me?
Yeah, we can hear you very well, Jérôme.
Okay, perfect. We're so happy to be part of this online congress. It's 4 p.m. in Paris now. It's snow days outside. It's very cold, and we have a complex case with my fellow asthmata jury. This patient is a 50 years old male referred for his third ablation. He started very early to have a persistent AF. He was 30 years old. He had 2 previous ablations, one PVI 5 years ago. He was doing well a few years after that with normal heart, no structural heart disease, normal LA, and he recurred with paroxysmal atrial tachycardias 3 years ago. And we did a complex ablation already in this patient with 3D RF in year 2022. We ablated two substrate for mitral flutter. The critical isthmus was corresponding with the anterior wall, and we did the anatomical line isthmus, AP, and endocardial on the lateral part of a mitral annulus. Then we induced another complex tachycardia, more complex tachycardia, in the posteroseptal area that we ablated on both sides, right and left. The right side was mimicking right-sided flutter, typical right-sided flutter, but PPI was not corresponding with tricuspid macro-reentrant tachycardia. So this patient, in other words, 3 years ago, received 2 lines, the CTI line, the mitral line, and he had focal ablations on the anterior wall and then both sides of the posteroseptal region. He recurred 2 months ago with a stable atrial tachycardia that you can see. I don't know if you see our large display with signals, real-time signals. Can you confirm, please?
Yes, we do.
Okay, so in green, bottom green is the decoupler catheter, which shows eccentric activation of the CS. The Stachy cycle length is just above 200 milliseconds. And we are using Medtronic Affera technology, and we already draw a map of a right atrium, which seems bystander. You have a first activation from the septum and the eccentric activation of the CS, and CTI seems silent. We use Medtronic Affera, decapolar catheter, 3 femoral punctures, and a conventional basic sheath SL0. So we are waiting now for the ACT to reach 350 before mapping the left side. We took more than 2,000 points within 2 or 3 minutes on the right side. Can you confirm, dear friends, if the ACT is okay? Okay. let's go on the left side. So the question is, what will we find on the left side? Is it really a stable AT? Or is this fibrillating somewhere? This patient has a complex substrate. One can see that Aphera reaches the left side. Mary is one of the engineers supporting the case. Can you keep the right-sided map, please? Both maps. So we are on the left side. No signals or far-field signals. Yes, we got signals on the Aphera, yellow signals. So the two major question is, will this patient have a focal substrate that we can target, or is it fibrillating somewhere? Will it be empiric anatomical approach or customized EGM-based ablation? So you discover in real time with us mapping of the posterior wall of this patient, small signals. And the second concern, let's say my second concern, is how to prevent disconnection of the appendage in case of anterior substrate, as the patient had in the past a mitral line. Maybe it's not present anymore, but we refrain generally from ablating anterior and mitral lines.
Jérôme,
So feel free to.
While you're getting that information, it really highlights on the right atrial map how careful you have to be to take in all the information, because it would be very easy to think this is right atrial flutter. You've got red and purple on the septum joining, but obviously you've got CS distal to proximal activation, which indicates it must be coming from the left side. So really being careful about the rhythm and the aliasing of the timing just highlights how careful you have to be to not be blindly fooled into thinking this is a right atrial flutter.
Yes, indeed. That's why it's critical to analyze CS activation before transeptal or before burning and everything. We won't. I love PPI, but we won't perform PPI on the right side because of the short cycle length of this tachy. I would be frustrated to break this tack with PPI. I prefer to take time to perform a nice high density mapping to identify the critical substrate of the critical area of this clinical spontaneous tachy. I'm not that maneuverability on the right side is not really easy. LA is not that big. So big loop, rotation. The septum was floppy. So right veins are disconnected, silent.
Let me ask the panel, Dimitris, do you use PPI? I mean, I like Jérôme try and avoid it and do activation map because I'm always worried that I'm going to change the tachycardia. What's your approach in this situation?
Since he started, I am also a fan of PPI, and I would like to have this information before, but I agreed with Jérôme that it's better to have a nice activation mapping of both atria. Hopefully it will be the mitral isthmus line that will be open. That will be the best case scenario for the patient in order to avoid appendage deactivation. In the left veins, there are potentials in the left veins.
Yeah.
Jérôme, do I see well?
Yes, there are things to do in the veins. First step, check the veins. Second step, find the substrate for this focal lateral tachycardia, and then consider more ablation. So, Mary, can you rotate anterior, please? I don't know if the audience is familiar with Afera mapping, is familiar with Afera energy. We mainly use Afera in our center due to price in redo patients, not for index ablations, and mainly for patients presenting with recurring atrial tachycardia, complex atrial tachycardia, because mapping is so nice and accurate. And stacking energies, it will be one of major questions in this case. Which energy do you use first? Where? What are the endpoints in terms of blocks, delays? There are so many things to learn to compare with what we know from previous studies using RF. It's really promising. So I'm not comfortable at all to move to the septum because it's floppy, with or without sheath, like a young fellow anxious to lose the TS puncture, you know. Mary, can you remove the right? Yes, thanks. The right map. So Mary is showing us that the septum is silent. Mary, what's the threshold for scar in this map? Zero, 0.55 to 25.
I think one of the things that we see about the Afera system is you have the same catheter that you're using to map, and potentially you're going to ablate with the but do you use those propagation arrows that the system provides as you're doing mapping in a tachycardia like this, and then how do you are you using it to determine if, especially since you're not doing entrainment pacing, are you using it to determine if it's focal versus reentrant mechanism? Are you at all using those that part of the technology?
Yeah. Yes, it's a nice feature. So one can see this blue arrow. It's not always present because in case of scar, no signals, you have no arrow. And this arrow tells you what's the local propagation. It can be confusing with arrows you have from other system, other competitors, depicting the contact or the projection of a catheter parallel or perpendicular to the tissue. Here it's propagation. Yes, it's really useful. During the mapping, it's really useful when you ablate, when you perform a line, when you do a line. Instead of remapping, once the arrow shifts, you can be sure that you have a block. Even if I mainly perform PPI along this line, if the tachy is not interrupted to know if it's another tachy, another map, or if it's just an incomplete block around this line. So how many points on the left?
What kind of... Excuse me, Jérôme.
Can you show us the voltage as well?
Yes, good question. Let's see the bipolar map. Mary, can you show us a propagation map on the left? A propagation map on the left, or let's say, and bipolar map on the right. you see this huge scar. I don't know if it's the disease or if it's ablation, previous ablation. Explaining why propagation is hard to understand around this scar on the septum. So we're going to discuss about the mapping strategy now. If everybody is happy with the number of points taken in this patient, we will redefine the reach. There is a vein mode feature. A vein mode feature, Mary will ask me to return back in the veins, the left veins, and we'll activate a dedicated algorithm giving more wave to points taken between veins and appendage to avoid tenting maps or false surfaces in this area. On se met le vein mode, Marie?
No.
The appendage is low, facing the veins. So veins are not disconnected, despite 2 RF ablations with contact force catheters. So we have veins not disconnected. We have substrate with fragmented potentials along the septum. And activation says that, look at that, posterior wall goes upward. Boom. Can we switch to AP projection, Mary? And anterior activation is hard to understand. Corresponding with something like localized focal. Yep.
Jérôme, what about the mitral line? Where did you perform it? It was a lateral line, as you said.
Yes, it was lateral.
In the previous ablation.
Yep. So let's redefine mitral line because it's not blocked, as one can see, except if we have a collision between green and blue here. Can you see on the left corner, upper left corner of Afera, there is a rainbow histogram. It's a new version of Afera, activation histogram. So we have 100% of this cycle length found on the left side. And here you have on the real-time signals, fragmented signals along the mitral line. With green and blue certainly corresponding with no mitral block, incomplete block. So no durable lesions left by previous ablation.
So I guess the coronary sinus activation tells you that it must be the mitral isthmus line cannot be blocked. Otherwise, you couldn't get distal to proximal.
Yep.
Correct.
So vein mode for
you map
more
just the veins now in order to isolate the veins only.
Yep. So let's start. First step is re-PVI. Is everybody okay with that? Yes.
Absolutely.
Let's go. So we're gonna PF. We're gonna PF veins. What's missing along the vein mode? Tell me.
What kind of sheath do you
This is
use
B.
for support?
It's a conventional sheath. It's a SL0, not steerable. We only use steerable sheath in this patient when it's hard to reach the distal CS with Afera. Afera is designed to perform PF, short PF pulses, 1 second, 950 volts in the CS. Sometimes it's hard to reach, and the steerable sheath is needed to reach there with position. So, can you show me AP? Allez, let's PF. Let's go. Let's PF the veins. And yes.
And Jérôme, do you use the activation to work out where the break into the vein is, or you're just going to go all the way around again?
And yeah, nice idea. Let's focus. Mary, can you see PA projection veins? So tell me where do you estimate the gap is? Please, Mary, can you rotate the bipolar map as well on the right? Let's start here.
Do you believe that the scar in the posterior wall is true, or it is a matter of contact?
Look at that.
I think it's true.
I honestly think that it's a disease and not a matter of contact.
Mm-hmm.
There are so many points. It's not only a question of number of points, but no. Unfortunately for the patient, I think it's fibrotic tissue and not only poor contact. Okay, let's get started. PF. Okay, still activated. So it's PF, of course, on the posterior wall. For lines, we prefer RF, mitral lines, CTR lines. We generally start using RF because I love having nice blocks.
Okay.
Plus 40 milliseconds.
Yes, very good.
It's amazing, you know, after 25 years ablating patients, there is only one rule, which is true every day, is disconnect veins.
The first rule of Fight Club is PVI.
It's so hard
Durable
after 25
PVI, right?
years of PVI technology improvement. It seems so hard to have a durable PVI in every patient. It's amazing. I don't know how nature is able to create reconnections, or how we are not able to have durable lesions.
Well, I guess, Jérôme,
I'm sorry.
the challenge we have is, safety versus efficacy. And so there's always this tension about doing a lesion that's good enough to permanently isolate, but not doing so much you cause esophageal fistula or perforation. So I think if we're not getting reconnections, we're doing too much.
Yeah. So the left veins are still not firing, but connected, not isolated correctly. So before having this tachy cycle length increase, I was telling you that we prefer to start lines using RF, except on the posterior wall. knowing that PF is studying everything, so you can have sinus rhythm restoration and block or no signals, meaning nothing. We do prefer to have sinus rhythm restoration and large blocks using first RF and then stacking energies with PF to make deeper lesions, even if we don't really know it's deeper, but how deep is it? So yes, there were questions. One of you asked, what's the lesion size? Mary and
We should explain that
what's the lesion size?
blue lines. The blue lines depict, the gaps between PF lesions.
Yep, exactly. Left veins.
Maybe in
have
this
normal
posterior part.
signals.
But maybe in this part of the posterior part of the left veins, you need it will be much easier to have steerable sheet.
Right.
But it seems that you might
Yes,
very
yes,
well, but
of
it will
course.
be a bit. Now we have maybe right flatted.
Yeah.
We have that
Right.
change in
Yep.
activation.
So let me end up this. Find to remove this blue line. Qu'est-ce que the short pulse? So left veins up there, it's still connected. Show me the ridge. Qu'est-ce qu'il y a? Sorry, but Afera is frozen.
So it's quite interesting that the activation has returned to CS distal first by the look of it. So maybe that you've got a dual loop with roof and mitral isthmus, and the PFA stunned the mitral isthmus for a while. It switched to roof, and now it's back through the mitral isthmus as its preferred route.
I'm sorry. I'm sorry. The patient was having low blood pressure, so we made an echo. Everything is fine, but I didn't hear your questions. Can you
Jérôme, we had
please
Yeah, we had a transient period where the CS was proximal to distal, and now it's gone back to distal to proximal. And I wonder whether there's a dual loop with the roof and the mitral, and the PFA stunned the mitral line for a short while, and now it's recovered again.
Yeah, it could be 2 loops or clockwise, counterclockwise, but mainly 2 loops, knowing the substrate the patient has on the posterior wall. It seems necessary. We're gonna check what's this stacky. We just would like to close, to disconnect these veins correctly, and to map or to PPI. So the tachycycle length is 260. CS is now back to eccentric activation. Can I ablate? Okay, well, something. PF, yeah. PF is back.
And Jérôme, we're being asked, how do you know about contact with the Afera? What do you use to guide whether you've got good contact?
So there's a green light up there, just behind ablating 2, 3, 4 seconds. For example, I had a poor contact. that's I had a poor contact. So my lesions are not blue, only gray. So it's a question of maneuverability, contact, fingers, chief. Try to find best contact. there is no other solution than to PF or to burn and to look at curves of contact and temperature reported by the machine during the pulse.
There is of course,
I have to
cycle
say,
time
this
is
is
the-
probably, right? This is one of the only PF catheters that actually gives you a real-time kind of thermal feedback, right? When you give that PF, so you see that little
Exactly.
blare of light or blare of thermal energy go off on that sphere. Tells you that your application is probably a good application. And those little white dots on the lattice catheter telling you have contact based on the impedance. So, I mean, there are some indicators that tell you contact with this catheter.
And do you trust them, Devi? I've found
So,
the impedance
Karina.
isn't terribly reliable.
I have to say, I mean, it's
But-
for trust but verify kind of thing. It's a first, for me, when I'm using it with ice, I as I'm mapping, especially, if I see a low voltage area, I take my time looking at it, making sure it's not a low contact issue, like it was said early. But I think when I apply a PF lesion, I do look for that thermal footprint. If I see the thermal footprint on the sphere while I'm doing the PF application, I think it does give me, I mean, it's 4 seconds, but still it gives me a little bit of comfort that it might have been a stable application.
I have no sound anymore from the Congress. In
Can
my
you hear me okay,
headphones.
Jérôme?
Yes, you're back.
Jérôme, I
No
notice
more
you're doing
signals inside the
PFA.
left veins.
I notice you're doing PFA on the anterior aspects of the veins. Is that your normal routine?
Yeah, always. It's our conventional workflow. So regarding this,
in the ridge region,
sec-
sometimes- Yes, excuse me. In the ridge region, sometimes we can apply even RF of Afera, which is very powerful.
it jumps.
Regarding the RF, Richard, let me just ask a question about, I mean, we used to do RF sometimes in the anterior aspect of the LA, but recently I've kind of switched to just doing PF everywhere in the LA, just like Jerome's showing. Even in the anterior ridge, I've kind of switched to PF because I've seen good durability even with PF. So I'm just curious what everyone's workflow has been. We felt like there was no reason to use RF in the LA, especially with how powerful that RF catheter is.
Yes, you're right. Yeah, so many things to investigate with this new RF. No one knows. We are using RF for every mitral line, and we prefer, based on Medtronic recommendations, to use PF around the veins. So no more signals inside the veins. Would you like me to go on the right of the roof? Okay, last application up there. Next step for this 260 TAC. Would you me to isolate right veins or to draw another map? Right.
It'd be interesting to see how easy it is to block that mitral line based on the CS signals.
Okay. So one says mitral line. You want to perform a PPI around? I would like
Can
to
I
just
Well, even
check
remap-
About the
right
posterior
veins.
wall,
Je pense pas que ça tourne entre le-
there is such a poor voltage in that posterior wall. There's definite substrate in that posterior wall. Would you address that posterior roof now while you're at it, or would you would you leave it be? If the tachycardia terminates, would you feel comfortable not addressing that posterior roof?
Not at all. I would prefer to isolate the posterior wall. Just because it's simple doesn't mean that I must do everything. But I'd love that this ablation would be the last for this patient. And I would prefer to isolate, yes, the posterior wall. It's a beautiful corridor for a roof tachy, even if it's not patent. Okay, look on PA projection, Mary. Right veins, how are they doing now? Are they really firing or connected? Please rotate.
Devi, while Jérôme is doing that, we're being asked by the audience what's the thermal footprint if PFA is non-thermal? What's the explanation for that thermal change?
Now, I believe that every catheter
Lisa?
has a slight amount of thermal footprint, right? I mean, it's non-thermal, but not. I mean, there is a small amount of thermal energy. I think the beauty is these mini electrodes show you those slight rise in temperature. But I do believe that most PF catheters have some form of temperature that we see, but just not as high as what we see with RF. I'm just curious what your thoughts are on that.
Well, I think that's how we
Thanks.
cook chips, isn't it? Oh, we got termination there.
Termination in the
We sure
inferior
did.
part of
Long termination.
right inferior vein.
Yeah.
It's amazing. It always reminds me what Michel Sager taught me 30 years ago, 25 years ago. Veins.
But that can't
So
can't
what's
be the
next?
mechanism, though, Jérôme, can it? That can't be the mechanism of the tachycardia, because the CS activation
No, I
is
know,
completely
I
wrong
know.
for a right vein.
I know.
But
It's
we
not
have to
because
isolate right inferior.
this area cannot be responsible for everything. I know. So before, it's not very exciting for the audience to look at me closing this or isolating these veins. I suggest that we go along the mitral line because the patient was having mitral flutter in the past. I would like to check veins, to check lines first. Okay, can you pace the CS? So I remind you that on this version of Afera, it's not possible to see non-spheroidal catheters or basic conventional catheters. So the CS is quite high or distal inside. The catheter is quite distal in the CS. Mary, can you pace the appendage first? Is there a clockwise block? On peut stimuler. Please pace on Afera. There's troubleshooting with cables. Okay, let's pace on the CS1. CS1, yes, let's see CS1. What about blood pressure, my friends? Oh, it's 9. It's better. Systolic pressure is good. Alors, can you pace CS1? No block. Okay, so
But
Pacing
no
map.
not a lot of scarp mitral isthmus.
yeah, yes, you're
Okay.
right. Can you rotate the bipolar
like-
map to identify where we can, where is the old line? Something precious is, please, can you show us the CS map we did with a right-sided map in the beginning? I would like to know where I can reach on the epicardial side the endocardial line. So I'm honestly, I need no activation map. I would suggest to perform line from here. Can you see this all scary potential? Oui. On n'en est pas là. There are questions from and troubleshooting questions with people supporting the case, but everything's fine. So I would start here, knowing that the activation delay before ablation is very short, it's plus 70 or 80. Do you agree on that? Right. So start RF. So it's 4 seconds RF. Là, tu fais quoi là? Oui. Yes, it's 5 seconds RF, 300 watts. So delay, no block.
Richard, there was a time when for mitral lines, we routinely used to do alcohol ablation just because we never got transmural
Right.
or routinely couldn't get transmural. I have to say that I have not used as much alcohol ablation in the last year, especially now with the ferrocatheter that we're routinely using. We feel like we're able to stack lesions a little bit better and maybe get a little more transmural lesions.
Yep.
And then we see, we've seen some data on durability with some of the other PFA systems not being so great. So I'm just curious what everyone's workflow has been for this.
Yes, we'll Marshall plan using ethanol or Marshall plan using both energy will be the future. As you said, we're not
PFA on the mitral.
Yeah, but I would like to have a block before, leaving no gaps. I refrain from PF because PF may lead to an exciting block, but transient block with early recurrence. I would prefer to have more 150 milliseconds along this line, only with RF because it's what we learned. No significant difference,
Devi,
no block yet, no improvement.
Devi, do you have to go into the coronary sinus with the Athera system then, or is it all achievable endocardially now?
1/3. 1/3 requires
I don't routinely
PF.
go in. Yeah.
In our series of 50
I'm sometimes
patients.
concerned about. Go ahead, Jérôme.
It's too hot.
So saying, Richard,
Cooling down.
Yeah, I do think that sometimes you do have to go to the CS, but obviously there is proximity to the coronaries over there, and I don't feel very comfortable doing ablation within the CS with the Athera system yet. Definitely in like right and lefts, I feel okay, but otherwise I just don't feel so comfortable.
Yes, I completely share this opinion. It's a really last intention. So, no block. No block. Just check X-rays. Oh. Où ça, tu dis? Where? No, I just want to check X-rays because the CS is so deep. Can you switch X-rays on? It was off after TS puncture. X-rays. Yes, maybe that it's spacing. I'm stupid. Above this line. So would you switch to no, switch to 5, 6 CS spacing.
Mm.
Okay, it makes no difference. Where is the gap? Where is the gap? Close to the veins. No signals. So what should I do? Should I PF this line? Should I put more RF somewhere? Should I go
Maybe better
inside
contact.
the CS? I think.
Can you do a quick activation? Can you do a quick activation along the line as you're pacing to see where it's breaking through?
Yeah.
Yes.
Okay, activation map above the line. So you see the blue arrow telling us you have no block. Jérôme, back on the line. Can we zoom in, please? Merci. Thanks, Mary. Far field, near field on l'affaire. Attends. Back. PA. Show me PA. Oh, so we have mapping frozen. Mapping frozen after the upgrade we did last week. There are several issues. This line is not that large, that big, that long.
Dimitris, can I ask you what your approach for mitral lines are? Is it PFA, RF, or a combination of both?
Combination. And we should remove the red dots now because we don't need them, in order to see better the activation in the mitral line.
So the mappers are fixing things. So the sphere 9 catheter is not displayed anymore. Sorry, it's back. Yes, it's back. Activation. It's loading a new map.
Can we ask Mary something?
I would say
Because I cannot see. What is the number of the target? Is it 600?
What number?
In the panel of the target. In a cyclet. Okay.
Let's RF this area. It's on the ventricular pole. And we have signals remaining. Yeah. RF. Pew, pew, pew. Above. Okay, nice.
Jérôme, are you ever using PF on top of RF and stacking the lesions to get more depth? Atul had a present,
Yep.
some data on depth. Yeah.
Yep. mainly, yes, it's RF in first intention, then PF once we know where we add a block. Stacking PF on RF, and third step or last step is PF inside CS. We have a slight increase of the block along this mitral line. How long is it now? It doesn't seem that long. It's not that easy to move up there. So how long is it? It's not huge. It's 120. So let me check what's missing along this line. V exclusive V potential. Okay, can you accelerate? I would like to know if it's double potential before V. Pace faster, please. It looks like maybe there is a jump, a picador jump over this line. Pace faster, please, on the CS. Okay. Any comments?
Yeah, there's definitely an A and a V there, isn't there?
Yes.
But, is it a jump or is it going very fast along the mitral line? Can you pace now? Is it possible to pace with Afera to see if we have a clockwise block? Afera pacing. No block.
No.
Before going inside, yes.
We should remap and remove the red dots of the RF lesions in order to see better the gap.
Okay.
Maybe it's closer to the ridge.
Okay. One last comment is remove tags. Yes, RF tags to map better. Okay, pacing CS 5.6.
So while you're doing that, we're being asked by the audience about the irrigation rates for PF versus RF. Can you just remind us, Jérôme?
Let me ask you. Le taux d'irrigation, the irrigation rate, Mary, 4 milliliters per minute. Basal
Then I
and
think
15 during ablation.
And I think it goes up
30
for RF. Yeah, 30.
Is it the same irrigation rate for both energies? Basal is 4. Basal is 4. 15 for PFA. And 30 for RF. 4, 15, 30. So,
approach
what about this block? Okay, do you want me to go AP in the CS to check? Okay. I suggest that we put PF on RF. So what are your suggestions, my friends? Tell me.
Yep, PF on RF. We're running out of time, Jérôme, so we've got a couple of minutes left, but PF on RF sounds good.
Okay, let's do that for the last minutes. And after that, we will certainly put a line on the posterior wall, check the CTI, and isolate the right veins and try to induce a patient. Okay, PF. It's not, I'm not stable.
You know, especially for the mitral line, you need the seat, the steerable seat.
Yes, it would be great help in this patient. Honestly, it's not, despite the LA is not enlarged, it's hard to be stable. It's certainly because
It's a
of
very
floppy-
soft and it's a very soft and forgiving catheter, but as you said, a lot of people have said that steerable sheaths can be helpful in certain areas.
So let's have a look on delay now. Heparine, ouais, on refait 2000. 2000 units more, please. Okay, try to pace on the Afera for the clockwise block. It's better now.
Well done. Well done.
Okay.
Perfect timing, Jerome.
So-
Perfect timing.
Yeah.
So thank you so much.
Hands up
That brings
with a
us.
nice block. You're
Yeah, well done.
welcome.
You're making me look good.
Thanks for
You're
your
making me look
advice
good.
and comments.
Okay.
Thanks to you all. Good evening.
So that brings us to the end of the
Right.
session. So thanks to our operators, Jérôme and Vladimir, for a great case, and thanks to Devi and Dimitris for their insights. You know, very interesting case. We've seen a lot of talk about the interaction of PFA and RF, and there we've seen it stacking lesions as a beautiful example. We've got a PVI case coming up in just a minute, so stay with us for the next session of RIO. See you very shortly.